Welcome to the Pura Vida podcast. My name is Dr. Gabriel Salgo, and I'm your host. Welcome, Dr. Datesh. Thank you very much for joining me for a very interesting talk. Very honestly, also very egoistic. Because unfortunately, I'm in the age where I need your help.
No, thank you so much for giving me this opportunity. I mean, this is something I've got so much passion about, and I've been working so hard trying to debunk so much about this over the years that I almost feel that it's criminal that people don't understand this problem and men have to suffer the journey of having something which is very much curable.
Yeah, exactly. That this is the point. I think that there is a lack of not just understanding, but information about it.
Exactly.
So it still seems, although it has nothing to do with sex per se,
No.
it is still in that area of genitals.
Exactly.
And it's embarrassing to talk about. It's something that we don't have. We don't have problems.
Yeah.
And that is also, unfortunately, I think, in doctors' mind. So they don't inform the patients. They are giving out the medication. They are doing minimal, how should I say, education on these. And this is why we are here.
Exactly.
So very excited, especially because what you really is very passionate about, and I really want to get it out, is the chronic pelvic pain syndrome.
CPPS, as it's
Correct.
known and famously called. Yes.
Unfortunately, not famously enough.
Not famously enough.
Because even I never heard of that
Imagine.
before, very
Imagine.
honestly.
Yeah.
And this is something that when I looked a little bit closer into it, is exactly what I'm having, except the pain. So we mentioned it before.
Yes.
It is slightly misleading because as soon as you have pain and you don't have it, you are dismissing. That can't be me. But it's such a complex diagnostic that the pain can be missing and you are still having the syndrome, and you need then much, much more than we usually get on a pill or herbal basis. So maybe we get into the beginning. What is the prostate actually doing?
Right. So the prostate is unique to men. Only men have it because it is a sexual
At least
gland.
something that we have.
It is. That is probably the only thing that we have that is special. So it is a sexual gland. Its purpose is to provide your ejaculate. Right? So your ejaculate contains two things. One is the prostatic fluid, which is like a lubricant, and also sperm, which is stored behind the prostate in a bag called the seminal vesicle. So because it requires that same tube from which we pee, it has been situated there.
Yeah.
And because there is a correlation to the bladder, it also plays a role in helping with urinary continence.
Yeah.
Because it has to close the bladder neck when you ejaculate to not allow urine to leak out during ejaculation, because urine will kill the sperm. So imagine such a precarious area
Very complex,
for the most important purpose of this body of ours.
Correct. Yeah.
So it's such an intricate gland. It has to have such a fabulous wiring between the brain, the spine, and all the rest of the bits around there for it to function in such precision. So that is where I think people have misunderstood the prostate and not given it enough airtime.
Correct. It's always the question is like, what does it actually do?
Yeah.
Gives a little bit of fluid to it. But the fluid is, I think the fluid is more alkaline, so that it protects the sperm, for example, because the vaginal fluid is more acidic to protect against bacteria and infection. So it is really incredibly complex and smartly done.
And very smartly done too.
Yeah.
So this little thing, which is so highly wired, obviously, if it gets injured or damaged, there can be a lot of collateral damage. So our entire understanding of prostatic diseases has been to manage the collateral damage. It was never
What do you mean by collateral damage?
So if you have a prostate which is inflamed, for example.
Yeah.
It's the glandular part which is inflamed. Now, 30% of the prostate in the central part is muscular.
Yeah, I think that's very important that we are making that it's not just a gland with the same tissue.
No. It's got two distinct tissues,
Yes.
gland and the muscle. So the muscle obviously is in the center because, as I told you, it helps with continence, right? So that, and of course the pushing of the fluid out, so it needs muscular tissue. So when you have inflammation of the gland, the muscle obviously goes into a spasm most of the time.
Yeah.
That spasm then makes it difficult for you to pee. But that's not enlargement now. It's inflammation causing that so-called symptom. And what is the regular treatment for this? Give you a muscle relaxant. How does that help? It takes away the symptom, maybe, to a certain extent, but it has not addressed the root cause. And that inflammation just goes on, and then it leads to other things. Chronic inflammation, as you know, can lead to a lot of other problems.
That is something that we, I think, should focus maybe a step later on. That really this little thing can cause heart disease. It can cause stroke.
There you go.
Depression, anxiety, and we go on and on. So these are the things. But altogether, usually we say, 45, 50 plus, then it starts to be relevant that we recognize that there is a prostate there due to the enlargement, not so much due to the inflammation. That can happen much earlier.
Very much earlier.
Yeah.
Inflammation of the prostate can start in your teens. And
this is something also new.
Because that's when your prostate is fully developed already after you reach puberty.
Wow.
So we are sat on our prostate the whole day. There's a link to viral diseases. I told you about the paper I published on COVID, right?
Correct.
So I looked at it now because I've got interest, but what happened 40, 50, 60? We never, years ago, there were so many viruses.
Exactly. It's not just COVID. Now, COVID brings everything up, and we have a huge pool of people who had COVID.
Huge pool.
And as you said, there's actually a big pool, and it was one of the first things that they realized that young people who were asymptomatic had fertility problems.
Exactly. So that fertility problems, as I told you in the past, a lot of times was not related to hormonal imbalances or even testicular dysfunction. It was actually prostate dysfunction because the sperms, I told you, are stored behind the prostate in the seminal vesicle, which gets inflamed along with the prostate. So that's why their sperm quality has dropped. And this is a worldwide phenomenon. All over the world, fertility rates have been compromised. And in a lot of patients, if you were, at least in my practice, when I look at them carefully, I actually find the problem is from the prostate, not from the testicles or from the hormonal imbalances, which people implicate the vaccine to do or whatever.
Yeah.
No, it's not that.
And we find very often that the hormones are completely okay, but there is still a problem with fertility and per se with the semen. So the first thing should be blood check for inflammation,
definitely,
which is very simple end of the day. And then what is the second diagnostic measure that you would do?
See, the thing is, the most important thing is for the clinician to have an open mind first. It is a known fact that this is something you can Google or ask ChatGPT, it will tell you. The most common ailment in a man medically is actually prostatitis.
Yeah.
Almost 1 in 3 people will have this in their life at some point. So if you think about that's bigger than cancer, bigger than diabetes, bigger than hypertension.
Oh, absolutely.
1 in 3. Come on.
And can lead to all these problems. I mean, this is also something that we have to emphasize.
And can lead to all these problems.
That the inflammation alone is helping stress.
Yep.
Stress is a hormone disruptor. Now everybody talks about BPA, BPS in frying pans, in plastics. But the biggest hormone disruptor is stress and anxiety.
There you go.
And if you have that, then you are going haywire. And we have diabetes, we have heart disease, we have all the, let's say, chronic diseases. And this is the interesting point, that a chronic prostatitis can practically not just lead to these other problems, but per se can cause what issues for a male? Actually, early. Let's leave the 50 plus, our generation, out. But the younger ones who are not even thinking about their prostate at all.
The younger ones will come into the clinic sometimes complaining of pain in that region.
But that's then pretty much already in a progressed state.
Oh yeah, so that can be. But what brings them to a urologist, especially in the teens or in the early 20s or 30s, will be usually some amount of discomfort, but they would have noticed a change in their sexual activity. So that's very important at that age.
Yeah.
A few of them, of course, I would say 30% out of them will have a change in how they pee. They feel that they are having repeated urine infections, which they correlate mainly when they have either a female companion or a sister or a mother at home who will tell them, oh no, your symptoms are exactly like what I have.
So it's burning.
It's burning, you're going to the toilet very often, you drink a glass of water and you're already in the toilet. So the ladies then start telling them, this is exactly what I have. And the problem is
UTI, yes.
There's no similarity. What ladies have is completely different. For their reason is the chronic cystitis, their short urethra, their periods, their vaginal health is different. Men, again, completely different. But the symptoms are similar. So they start thinking it's just an infection or it's not drinking enough water. So they go into this vicious cycle. They keep going to a general practitioner who, not wrongly, but wrongly taught probably because of our education, keeps treating them with antibiotics, which sometimes act like anti-inflammatories and neuromodulators.
Oh yeah, short-term,
they get
definitely,
a little bit of short-term relief, but then they are also advised to drink more water. So now the person who probably needed to drink a liter and a half at the most in a day is drinking 3 liters. What happens if you drink excessive water? The body just throws it out. So now your bladder is getting full every hour. So you're in the toilet every hour, but now you're peeing loads of white color urine, which is just water being thrown out. And that becomes a way of life for them. So they haven't addressed the real root cause. They found a so-called hack, they think, because the urine is clean, it's not smelling, blah, blah, blah. And yes, every time I go to the clinic, the urine is clear now. But yet, I'm still having this frequency. Oh, that's just maybe because now I have a small bladder. Or maybe this is just me. Or my mom has told me she's been having this all her life. So it's okay for me to have it too. And the story goes on and on and on.
So what would your advice be on that stage?
Very simple. No man should have the urgency to pee. You need to pee, you should be able to hold it. You only need to go, yes, if you have not peed for 12 hours, 24 hours, it's just a different story. But today, if you have the feeling you need to pee and you cannot, you should be able to ignore it and move on and go on. You should not start getting jittery, running around, or for that matter, even leak. If you do end up leaking urine, of course, that's really something quite severe already. The other thing is, very important misconception amongst men is at some stage in your life, you are going to get up to pee at night.
Yes, unfortunately, yeah.
Oh, come on, for God's sakes. I don't know who created that. I mean, maybe it was created for the right reason because 200 years ago, there were no urologists. Maybe. So it's
no, they were not.
So rather than going and seeing somebody who's practicing black medicine or black magic or voodoo, who knows, going to put something up somewhere, you just live with it, man. But now you must understand that's actually a disease. It's actually not a good thing because it leads to so many other things. It doesn't allow you to sleep.
Correct.
Gives
Again,
you
complete hormone disruption.
Disruption. And the most important thing which people don't realize is in the elderly age group. This is one of the most common causes of death in the elderly. How? You get up to pee, you fall down in the toilet, you fracture your neck or femur. In 6 months or 1 year, you're gone.
Yeah. 70%. I think after
death.
femur.
You know that. And that happens most of the time from a fall in the toilet.
That I wasn't aware of.
Oh yes, it's such a something that it's not spoken about enough. It's such a common thing to happen, and that fall most of the time in that age group happens when they wake up to pee.
So, but there I must say it's also a little bit of our fault, or a little bit maybe mainly, because we are supporting these theses. Yeah. Oh, you have an enlarged prostate. Yes. Okay, then there is nothing else you can do than going more often. And if you are not going more than 2 times, then okay, then it's okay. Then just leave it. Take an alpha blocker. Maybe it helps. If it doesn't, I had unfortunately horrible side effects from alpha blockers.
Of course.
Muscle pain, and couldn't take them. So it should be not just the patients who are educated, but I think also broader, the doctors.
I mean, the first thing is to accept that this symptom is not a normal symptom.
Yeah.
You're not supposed to have it. And it's not always related to a sleep disorder or OSA for that matter, or whatever. It's not always that. So to understand that prostatic problems can start at a very young age, it's not exclusive to older people. To understand that it's already well known, most problems in our body start on the background of inflammation.
Yeah.
So why isn't prostate issues also linked to that, or that should be the first thing that comes to mind rather than enlargement?
Mm-hmm.
Also to understand when something looks enlarged on a scan or physically, it can be hurt, meaning it can be inflamed or injured. It doesn't need to be enlarged. So if I went to the gym and worked out today and built a muscle, it looked great. But today, if you took a stick and gave me a whack and I put on my coat,
also enlarged.
It looked enlarged. It looked exactly the same.
Very good analogy.
But there's two pathology is different. They're two different things. And that is what I think is wrong with the prostate. Because if you leave that inflammation going on and on and on for decades and decades, tissue dies, that same tissue becomes scar tissue, and that's when you actually get a physical enlargement of that accumulation of that fibrous, non-viable tissue.
And that's in the which part of the prostate?
Mainly in the glandular part.
So the muscle is still
remains, but
untouched.
it of course goes into a spasm, maybe gets dysfunctional because of the inflammation. But the glandular part is the one that then becomes so-called enlarged. And another thing, which is of course a misconception, is the prostate has to be of a certain size in everyone. Rubbish. It all depends on genetics, your sexual promiscuity or your sexual activity. Forget promiscuity, probably the wrong word, but how sexually active you are. So I have seen patients of a certain genetic background who have prostates 3 times the size of an average Malaysian, and they pee perfectly well. They have no inflammation. They are perfectly happy. And that other Malaysian patient of mine who has a prostate, 30% of that can't even pee. He goes into a retention and needs a catheter put in. So that tells you that size doesn't correlate to problem. And that's another misconception that, well, I don't know whether it's Big Pharma that has taught us this, because now we have drugs to shrink the prostate. So maybe there could be that bias. So if you're above a certain number, please start this pill because it'll bring the number down.
And I think that was, to be fair to Big Pharma, that was already there before.
There you go.
Before these medications were around. So I think it's more the easy way out. So I see something, it's big, it definitely had exactly. So usually it's less large. So this must be the problem. And the inflammation in any kind was for years overlooked. I mean, if you look at the cholesterol levels, without inflammation, high cholesterol levels don't do that much, even if it's low density lipoproteins, so very low density lipoproteins. Without the add-on of an inflammation anywhere in the body, they are not causing as much damage as they do with an inflammation.
Absolutely.
Correct.
So men need to start paying attention to themselves in the sense the habit of urination should be something which shouldn't bother them. So that's thankfully a very good thing that most urology texts teach us, that you only should treat the bothered man, not every man with an enlarged prostate or whatever marker that is increased. You don't treat them unless they are so-called bothered. So that is the important message men should have, that at no stage in their lives should the urination bother them. That habit should be a clear-cut, simple excretory thing. Go into the toilet, excrete, walk out, then go back in again. Many hours later, repeat. You shouldn't be, I don't know whether I can pee now, or I just went half an hour ago, I need to go again, or it burns every time I pee, or I'm dribbling every time I pee, or I soil myself every time I pee. So many young people have this problem. There's always a drip or 2 drips of urine left in their underwear after they finish. It's all part and parcel of some spasm going on inside. And of course, spasm happens at the background of inflammation.
Okay. Can you go then through the process if you see a patient like this, let's say younger age? Again, let's leave the enlargement out first. What type of diagnostics you have to do? Because I think that's important that people know that and ask for it. If it doesn't happen, which I think is very often unfortunately the case, especially in let's say in faster working hospitals where the time is not there, that they are aware of, hey, that has been left out, I'm asking for it, or I'm seeing another doctor who is more experienced in that. So what are the steps, what diagnostic measures are you taking?
So for me, of course, at the moment, because I do this so often and I see this literally every day, for me the history is very important. The moment somebody walks in, if his symptoms are more irritative rather than obstructive. Obstructive means it's difficult to pee, or I have to push, or the stream is very slow, versus irritative, which means I go very frequently, I have urgency, I dribble, I get up at night. My mind straight away goes into inflammation.
Okay.
A quick diagnostic method I have is to do the prostate examination the right way. Now, why I'm saying the right way
is something that
is because we have been taught to do it for the wrong reason. We've been taught to do a digital rectal examination to determine if the patient has cancer.
Digital doesn't mean with a computer,
No, with a
but
finger.
with your finger.
Just the
so
finger.
I think we have to explain it
Just
today.
the finger, digital, with just the finger. So in medical school, we are taught to do that examination to rule out a prostate enlargement or cancer. First of all, the prostate is a 3-dimensional gland. You're only feeling one surface.
Yeah.
So how do you tell enlargement? Wrong. Number 2, cancer. You can only palpate
If it's
a stage
already
4 cancer.
Yeah, correct.
Maybe a stage 3B or 3C, they call it, cancer. What about stage 1, stage 2? So again, what is the point?
Nothing.
But yes, on the rectal examination, you feel first how firm the prostate feels. In inflammation, the prostate is no longer soft like this. It's firm. It's a bit harder. And the most important thing, it is tender in most patients. There are some in whom the tenderness has gone because of the chronicity of it. But in most young men, it's the pain. They will hate that examination. Not because I have a big finger, it's because you know where to press. There are points in the
So
prostate.
basically not the entering is a painfulness,
No,
but really pressing on the prostate.
Pressing on the prostate on certain key points, that's where you elicit pain. And the moment the pain is there, the diagnosis to me is clinched. But now to give it a bit more credibility, I will usually do a urine flow test, in which the flow will almost always be slightly abnormal. So there are certain parameters in the flow test. We look at the speed, duration it takes you to pee, how the graph actually looks like. It should look like a bell graph.
Just the strength of the stream, so how fast it comes out. Yeah.
And how long it takes you to empty yourself and how much is left behind. There will be some abnormality in that so-called, in those numbers. And the second thing, which is most important to me in terms of giving it a real diagnostic sort of value, is the transrectal ultrasound. You put in the ultrasound, you will be able to see the inflammation in terms of calcifications in the prostate, which are never given importance, because calcifications in the prostate are not linked to cancer. Calcifications in your breast linked to cancer. Calcifications in your testicle may be linked to cancer. So over the years, they found that calcification in the prostate did not link to cancer at all. So that is why we have been taught to ignore it. But what is that calcification? The biopsy studies have confirmed it's inflammation. So why isn't that been told? I had to dig this up from old records and read.
It's very interesting. And how fast after the inflammation started, is a calcification visible
Oh,
in the prostate?
I wouldn't know. But it's definitely years. It won't happen overnight. Oh, it's
so
going to be.
there definitely we have already damage, not just in the prostate, but we have also damage practically in other body parts like the vessels, like in the kidney. Yes,
Potentially. But I guess starting in the prostate is something that can happen to everybody, irrespective of their lifestyle. Because, as I told you, we are sat on our prostate the whole day.
Yeah. So, and again, the genetic part comes to it. Yeah.
Maybe to a certain extent there is a genetic predisposition, and the other thing is, of course, the viral thing. Now that there's not many organs in our body that get damaged by a virus.
Yeah.
So the lung is one. Now there's even the heart, for that matter.
Yeah.
Well, prostate
Or
proven
bacterial. I mean, bacteria.
Bacteria also.
Yeah.
So that is how I go through the diagnostic algorithm with my patients, and just with this, without really needing.
So you don't. Sorry, to interrupt. So you see through the ultrasound, the transrectal ultrasound. So that's very important. It's not on your
it's
tummy. Practically, it has to be transrectal.
Because you can't see the calcifications otherwise. Transrectal gives you a direct view of the prostate and also of the seminal vesicles, which too will be inflamed.
Okay, so we have an early stage inflammation. Do you need the blood test for that?
Generally, I don't do it. I would at most do a urine microscopy just to prove to them they have no UTI.
Okay.
The urine usually will be clear.
So
at most,
no CRP?
No, I don't usually do that because there's a cost issue. And number two, I am not so well versed in how to interpret that result at low levels.
Yeah.
I know a CRP is 200. I know I'm worried.
Yeah, exactly. And this is exactly the point.
3, that's when
This is an interesting point for me because this is then practically a low-level chronic inflammation where, if you say even before calcification happens in the prostate, you're going maybe 2-3 years. This low-level inflammation already is damaging a lot of your organs, eyes, glands definitely, thyroid, pituitary, testicles, ovaries. We don't have, but end of the day, the inflammation, male or female, doesn't matter, and it doesn't matter where it comes from. So this is where we have to emphasize. So in male, it can be very much even at younger age. The prostate, because it can be also your elbow, it can be your knee.
Yes.
It damages the whole body. So it's very important that we are catching it. And so if you don't see calcification and you still have the symptoms, you would say if 2 boxes out of 3 are ticking, you have an inflammation. You're not going further, and
I would just stop at that and be happy already to label them as heavy.
Label it. Okay.
As this is what it most likely is.
Makes sense.
So, and of course, the other reason why I've kept it simple is because now that I have a simpler way of managing it, I think, well, my thinking is that I put you through that treatment first. Only if you don't get well, then let me start ticking other boxes where I do more extensive scans, maybe an MRI, maybe do an endoscopy. So the amount of endoscopies I do for people who have trouble peeing is now 10% of somebody else.
So on the MRI, what do you see more than in a transrectal ultrasound?
The transrectal ultrasound is actually, to me, the best for looking for inflammation. But the MRI potentially can actually give you, if you do like a multi-parametric MRI, it can actually give you what the tensile strength or the rigidity of the prostate is real based on the MRI picture. So that can add on to the so-called diagnostic value of what do you call? They can give you more value in terms of it's more credible compared to an eye looking at it. This is now a machine telling you this is the reading, and the reading means this.
Okay.
But it's rarely done because, first of all, the radiologists themselves are not really very trained, or not. It's not a common thing to report inflammation. Not, they report in enlargement. They can report cancerous lesions, suspicious lesions. So they themselves are not looking at it. But yes, if I was today need to do an MRI because my transrectal ultrasound is not telling me something, I would probably think about doing it. But it's very rare. I've hardly ever done it. And I would then tell the radiologist, look, I want to see inflammation. Inflammation means there are certain readings which will be high. There'll be a differential, the tissue would look slightly different, so-called hotter than the other side. So can you tell me, based on the MRI, whether that diffusion difference is there? So definitely there is a value in it to a certain extent.
Would we have a different type of alkaline or acidity in the ejaculate? Would that be an option also for diagnostic measure?
Definitely there would be a role. There would be a role to look at the ejaculatory fluid, to look at its acidity, one. Number two, also to look at the white cell count, which should be 0. And they'll always have white cells in the ejaculate. But here, again, the value becomes a little less important because you can also have white cells in your urethra sometimes.
Oh, yeah.
So exactly. So that's where, differentiating between is this pre-existing urethritis or is this prostatitis becomes a little bit difficult. So giving that test that much importance is not easy. And it's also not very accurate. The other thing, what's doing, let's say, ejaculate culture. Now, we believe that it should be clear. Who told you it's supposed to be clear? We have commensal bacteria in our body.
And the prostate has a microbiome. It has its own microbiome. So that I think it's pretty new. I mean, the knowledge that
E. coli is there.
Yeah,
it's there all the time. So they will. I've seen culture of the ejaculate growing E. coli, not in a very high content. Nowadays they do the super sensitive cultures. Usually it used to be only if you grew 10 to the power of 5, it grows. Now you can grow 10 to the power of 1 also on the medium. And it'll be E. coli, which is sensitive to every antibiotic on the list. That should be enough to tell you that this is the good boy. He's not the bad boy. The bad boy will be resistant to a few, at least. So if you see a sample which all sensitive, I take it for granted this is a commensal. I don't treat it.
Okay. So you have practically then the anamnesis, seeing the history of the patient, having digital and transrectal diagnostic, and 2 boxes ticked. So you say, okay, now starting treatment. What would the treatment be? Because I know that it's very special, and you are pioneering this, not just in KL, but in Asia altogether. I honestly don't even know in Europe many people doing it. So
where I first heard about this and where I first was exposed was actually in Denmark, in Copenhagen. So they were doing it. They were already doing it at the time, but I think somehow they lost interest. They lost interest after a while because
they don't have enough male.
And I think the problem is the clinicians themselves are not doing it. They got a physio to do it. This is something that a urologist has to do because you have to see how it benefits the patient. So I think that's where that link went off. And of course,
how did a physiotherapist?
It's because it's after all using an equipment and applying it on a certain part of the body to send shock waves into the perineum. That can technically be done by a therapist.
It's very often, for orthopedic.
That's the same thing as saying your nurse can stitch up the skin also, right? You don't need to be a doctor to do that. It's the same thing. So anyway, so I think because of that so-called knowledge did not pick up, did not become well known, and people lost interest. But I found it interesting because I always believed that physical treatment had a role in medicine, which we forgot because of chemical treatments. So physical treatments, once upon a time, very, very popular.
Again, I think we have to clarify this to the listeners. Physical treatment means anything where we are using anything like cutting, shockwave therapy, ultrasound,
even massages,
warm pack, cold therapy,
packs.
Whatever. So this is then physical therapy.
Basically physio also.
Correct.
Stretching or whatever. So all this has a big role, but it's slowly being forgotten, or it's mostly been forgotten.
I think there's many, but we don't do it. As you said, it's more outsourced to therapists because we don't have the time for an hour to show them how it's done. But using machines for physical therapy, may it be again some heat, etc., that is still, I think, in doctors' hand, and so it should be more emphasized.
Should be
Absolutely,
strengthened. So one of the other things that spurred my interest was, for the longest time, I had served in the government service in a part of the country called Kedah up north, where it's still very traditional. People are still very
laid back.
Laid back, and they still believe in a lot of holistic medicine, traditional medicine.
Which is good. Yeah.
And one of the things which they culturally believed in was a certain type of massage for the perineum, which was good for men's health.
Interesting.
And this is something which in the past was never done for a sexual purpose. It was just done for the men, because they know the man is sat on the perineum the whole day.
Yeah.
It gets tight over there. So you need to just give it a little bit of a rub, increase the circulation, improve the circulation and of blood and whatever, remove the toxins from there. And because of that, he'll pee better, you'll have better erections, you'll have better sex.
It's a traditional...
And it's traditional.
Massage technique.
It's traditional massage thing. Like how,
In Kedah.
I'm sure you would have heard, this one is more popular in Thailand and all, doing prostate massages.
I heard very vaguely, but it's definitely
something that's
not
quite
in medical school.
Not in medical school. We only hear about that when we are trying to collect prostatic fluid for a culture.
Yeah,
But that little massage thing is also done in centers where they are touting it as a good thing for your sexual life. And to be honest, there is a rule for it. Not that there isn't. But it's a very uncomfortable thing to do, and really, something, if you had a choice, you would rather not do.
Not do, definitely, yeah.
So, putting that knowledge which I had, seeing this awareness created in a small little convention in Denmark, and then coming back to practice.
And that was shockwave therapy. Just to spell it out.
Shockwave therapy for the prostate, not for erectile dysfunction.
Yeah.
And then coming back to my private practice, where now suddenly I was exposed to this group of young men behaving like what I thought old men should behave, because when I was in the government hospitals, I'll be seeing old men who now require a surgery to remove the prostate or trim the prostate, who have been having urinary symptoms for the last 20 years, but were managed by the local health clinic with muscle relaxants all this while, eventually land up on my table requiring surgery. Now I'm seeing the guy who's requiring that muscle relaxant, who is now 20 years younger.
Yeah.
And I'm wondering, oh my God, the problem started here. I never saw that patient at that time when I was working in the government hospital. But now in private practice, I'm seeing you at this stage of your life. And I'm wondering, why are you having problems now? Because when I saw you at that 50 or 60 years age, I did not reflect back 20 years.
Of course.
I'm seeing you now, I'm going to treat you now. But now that I'm seeing you at 30...
And surgically.
And now that I'm seeing you at 30, I'm wondering, why are you suffering from this? Because I remember only 60-year-olds have this. And that's when I realized, no, actually, I'm seeing that 60 after 20 years of him having being treated by another doctor. But that's what got me thinking, oops, I think I'm missing out something. And that's when, thanks to a physiotherapy book written by an Italian physiotherapist who invented visceral manipulation. I'm sorry, I've forgotten his name. It's very famous. He mentioned about how important inflammation of the prostate is and how prevalent it is.
Again, I think we have to explain what visceral in that...
So visceral manipulation is when a person externally uses fingers and can actually manipulate your organs inside. Your liver, your gallbladder, the bladder, even the prostate for that matter.
Correct.
And this is something only very specialized physiotherapists know how to do. And
it's not easy and it's not undangerous. I mean, doing it in a wrong way...
It can be extremely dangerous, of course. Yes. So that also then spurred my interest, and fair enough, I decided to do a little bit more reading, and that knowledge is there. I didn't have to look too far. It's there to tell you that most patients actually have prostatitis. Most patients have non-bacterial prostatitis. 90% of prostatitis is non-bacterial, yet first-line treatment is antibiotics. What happened when we are trying to champion antibiotic resistance, using less antibiotics in society, in the community? How have we urologists escaped this dogma? How have we been not exposed that we need to look at this? Because we are one of the highest users of antibiotics like fluoroquinolones, like ciprofloxacin or levofloxacin.
I think the reason is because of lack of education on the patients and this little bit stigmatization of this is the genitals, this we don't test, we just put it in and
Because
hopefully
it's
it works.
genitals, it must be sexually related. That's another stigma. That today, if somebody has prostatitis,
And to measure again, you would either need to pee or give a semen probe, and then it takes 3-4 days until we have a result from the culture.
let's dispense the antibiotics and get on.
Correct. Yeah.
That's
So
true.
this is very typical also for other parts. I mean, if it's dental, if it's end of the day, I still see that too many people are getting, especially augmentin. That is the go-to medication. If to cough twice, it's augmentin. Yeah, go ahead. Although it's a viral infection, although bacterial infection is not there yet. And then why always this poor augmentin? I mean, this guy is. I mean, every bacteria is resistant to it already. So it's changed a little bit, but it's because also the patient requires it.
Yeah.
I mean, if you don't give it to them, so why don't you give it to me? I obviously have something, it has to be taken care of fast, give me something.
Correct.
Yeah.
So there is that push or pull factor from the patient himself also.
Correct,
And the doctor sometimes is just caught in between. Fine, go ahead. Yeah, take it.
And most people like you or myself, luckily, don't have the time. If I see that the poor housemanship doctors or medical officers, are they called in Malaysia, they have to see like 70, 80 patients a day.
Yeah.
How do you have the time to explain something to the patient, come back in 4 or 5 days, we do something again? He's happy that this patient doesn't come back at all, because that would add to his workload,
Exactly.
go from 80 to 140. So I have an understanding, and it's not something where we can do anything against it. It's more also on the patient. Sometimes I think that they invest time and money and effort to seek somebody who has more time and has the expertise. Again, medical officers have not the expertise nor the knowledge. I mean, they have a very, very good knowledge about broad spectrum, and if you are sick, very sick, they will definitely help you. But in chronic diseases, it's very difficult to pinpoint what is actually the problem.
Yes.
So even you tell, so it's not easy to diagnose. You have to tick the boxes, and then you have to go into the therapy. So your major therapy after the diagnosis is the shockwave therapy.
Correct. That's what I do.
So what is it actually? I mean,
So it's using an energy called shockwave. Shock waves are actually sound waves which are traveling at a certain speed. At that speed, they can have a physical effect. So an ultrasound is a type of a wave, but it's not a shock wave.
Okay.
So we have radial shock waves, focused shock waves, linear shock waves. All of these waves have different speeds at which they are traveling, and thus they have different effects. Some will just merely do a little bit of a massage for you. Some can actually do more, like create microscopic injury to initiate healing.
Mm-hmm.
Some can even stimulate your body's dormant stem cells to wake up and start making
what happens
new
with
structure. What happens with focused shockwave.
ED,
exactly.
for example. Yes.
So what I use is something called focused shockwave, where the wave travels at the speed of 10 to the power of 5 meters per second. This is the same wave we use to break kidney stones.
So that's actually what the very beginning of shockwave therapy was, breaking kidney stones, where you didn't need to operate.
The first non-harmful purpose of the shockwave was to treat kidney stones. The first purpose of it was actually to destroy tanks, and that's a different story.
No, that's actually a very interesting story. Seriously.
This was actually developed by Hitler's regime, this wave.
Okay.
So they commissioned this company, I think it was Stotz,
Stotz?
They were actually making weapons once upon a time.
I have to look it up, because they're really famous for medical devices.
So I think they or their parent company or somebody related to them was making war equipment. And he commissioned them to make this wave where they could fire it from far away without sending any arrows, just a sound. And if it hit a tank, apparently anything in the tank would explode, meaning the occupants.
Wow.
The earbuds, the eyes will explode. So this
is new and very, very interesting. I have to look this up.
Unfortunately,
Yeah.
he lost the war before they could apply it practically.
Okay.
So the same company then decided, okay, look, we have this technology. We have already learned how to hit two particles together to create a wave.
Correct,
sound.
yeah.
Let's do something more beneficial for
In an
mankind.
intensity, I mean, we must say that the intensity of a shock wave created by any of these devices compared to ultrasound or any other type of wave is incredibly intense, as you said. So it's
intense.
10 in the potency of 5.
Yeah.
Ultrasound is nothing.
Nothing at all. Yeah. So that's why
it's not even 10.
It's sub-zero,
Yeah,
whatever.
yeah.
So then they used it and miniaturized the whole thing and realized, we can break things in the body without causing much collateral damage.
Correct, because it's soft.
It's soft.
On the soft tissue, it doesn't have the effect because it travels through it.
Through it.
But
On
anything
something
hard is then cracked.
So they did that, and there have been some studies where after looking at the renal samples of patients who have had shock wave, they were quite surprised there was no real injury to the kidney, because they would expect that. And in some, they actually found neovascularization or growth of the kidney. The kidney tissue actually grew. So there was some regeneration. So that's what I think spurred somebody intelligent to say, hey, looks like we can create healing with this wave. But if we did lower the intensity and played around with it. So one of the first places where this was actually tried was on diabetic wounds. They shockwave the wound from the top. Within a week, the bed is red. And
that's interesting.
And today, we're still not using it because I
know it from aesthetics, for orange skin, for these type of things, that shockwaves were used. But it's still not a pleasant experience. And also the cost is quite high.
Correct.
So there the benefit wasn't as high as the cost and the pain that people experience. So they went away from that. I think
that's probably what.
But in wound care and in ED, for example, it's of course extremely interesting.
Interesting. So then they found that it could help with ED, and during that time they found there was a role in Peyronie's disease. But now, fast forward all these years, we find that it doesn't really do very much for Peyronie's, except it does take away the pain on the scar tissue. So when they have a bend on the penis, there's usually a calcified area. Sort of a
so that is also something maybe we should explain what that is.
So Peyronie's is when you have some injury to the penis, and that has created a tear in something called the corpora cavernosa, where your blood circulation is. And that leads to a scar,
which is a muscle.
Or a plaque. It's not actually a muscle, it's actually a tuft of blood vessels. A tuft of blood vessels, which has the covering of the corpora. That covering is called the corpora cavernosa. So inside is all a tuft of blood vessels inside. So that tears, blood leaks out, forms a scab, and then you get like a plaque. And that plaque, then if it's very big, it causes the penis to bend. It pulls on that one side. Sometimes that plaque or that area can be very, very tender and painful. And the logic was, since it's something calcified, why not try to break it with shockwave? Makes sense, complete sense. So it did. It did do good things, but it never really straightened the penis, because that is what men wanted the end result to be.
Of course.
But the other thing which they didn't realize was it actually did take away the pain, because it used to be very painful. So that ways it worked very well. But unfortunately, most men were more concerned about the bend. So that's why for that, unfortunately, the results are not that encouraging.
But it also then helped with the revascularization, so more blood vessels, more blood flow. With that also, it's a harder erection.
So I think that's one of the reasons why the men probably got upset, because they now are probably having better erections, but were still bent.
And the bending might be then even more pronounced on
so
that.
I think that's probably what happened. So then, fortunately, somebody decided to also use it on the prostate, finally.
But you have to use it on a different place, but it's the same.
Different. It's the same wave, using a different type of probe, and in a different region altogether.
So you are not going transrectal?
No, all external. Just below your testicle, between the testicle and the anus, is a hollow area. That's called the perineum. And that's behind that skin and muscle is your prostate.
So you place practically a little. The head is obviously
it's a
completely
circular
different.
head,
Yeah.
and it's placed
Yeah.
right there on the skin outside, and the wave has a penetrative depth. It goes in a certain amount of cm or centimeter before it creates that spark, where it has a physical effect. So the probe has been made in such a way that it only goes in an X number of centimeter, which is quite consistent in all men, because no matter how fat or thin you are,
How many centimeters are
5.
this? 5
3
centimeters.
to 5 centimeters.
Okay.
And no matter how fat or thin you are, there's no fat in your perineum.
Yeah, correct.
So
It's
that
just
distance
skin,
between
yeah.
your prostate and the skin of the perineum is consistent among men.
Oh, that's interesting.
So that is why it's quite straightforward to
And
treat.
how long does a treatment take?
10 to 12 minutes at the most.
And it's really just hold on, and a little discomfort is
you
likely
can have
there.
a lot of discomfort sometimes. You can, because if your inflammation is bad,
Yeah.
it is actually quite painful. But it's a good type of pain. It's like going for a deep tissue massage. Because at the end of
Yeah,
the
I don't
session,
like that.
most people don't. At the end of the session, you are relieved. You actually get up
Yeah.
feeling, whoa, what happened here?
The massage stopped.
Massage stopped, and of course, now I'm feeling better also. So they don't leave the clinic in any pain whatsoever.
Yeah.
During
So
the
it's
session,
just really the time,
time.
where it's applied.
there is
It's,
some discomfort, and there needs to be. And
Yeah.
that is why it was very important why I did it, or am still doing it myself.
yeah.
A lot of clinicians saw it, tried it once, and got their therapist to do it after, a nurse or somebody. And they didn't have this understanding on where exactly the nerves are, in which part of the prostate, how many areas of the prostate you should treat. That is not there in theory.
You can change the area.
I can be, of course. The shockwave comes out in a thin line like a needle.
So even if it's like a ball,
It's still a needle that comes out. The shockwave is only coming out from right in the center like a needle.
okay. So you're practically just like we did in the old video games, where you had there I'm shooting all the aliens.
Absolutely. You just send a bullet like
Exactly.
Exactly.
Space Invaders.
Space
That
Invaders.
was that.
That's the one.
Yeah.
I played that. So that's probably why I understand this. Okay. So there's a certain regime I've developed over the years of doing it.
How many? Sorry. So 10, 15 minutes,
Yeah.
one session.
Yeah.
How many sessions do you usually need until you have a substantial improvement?
4 to 6.
Oh, that's nothing. That's
So
very,
I do
very
only
fast.
10.
Yeah.
There's enough science out there to say the more you do, the better it is. But since there's a cost issue, there is a time issue,
issue.
there's an effort issue.
Yeah.
So we have to limit it. So most studies which are credible do anywhere between 8 and 12 treatments. So I chose 10. I
Yeah.
chose the middle ground.
Yeah.
Published a paper on it.
Yeah.
So now my 10 thing also is there in literature. And for the last 5, 6 years, it's consistent. I only use that one regime, one setting, and one type of protocol I follow on
Yeah.
how many areas of the prostate I treat at a time. Pretty happy with the results so far. Pretty happy.
And how long does it last? As I said, you practically pioneered it again, also for the Malaysian government, who now practically puts it into place.
Yeah. There is some recognition for it at least. That
Yeah.
it's
I think it's very, very important,
it is.
and it should be not just in one country, but hopefully
all over the
the world, because that will increase again, not just for patients but for doctors.
Yeah.
The understanding and diagnostic measures. As you said, it's not really extremely difficult or problematic or
Exactly.
costly. End of the day, it's pretty simple. So you have then the 10-15 minutes per session, 10 sessions. When do you check the patients again?
usually 6 weeks to 3 months later,
Okay.
where to give them a more objective result, I will always ask them to repeat the flow test,
Yeah.
and also I'll repeat the rectal exam with the ultrasound. Here the key always where the so-called selling point where now I'm going to get a return customer
Yeah.
is when I do that rectal exam and they are shivering because they remember the first exam.
Yeah.
That pain, that discomfort. And even before I can start, you can already see they're in pain already. But the moment I go in and I ask them, how do you feel? Huh? are you in yet? Not the right thing to ask, but they will actually not even know that I have done the examination.
And touch the prostate. I mean, again, the prostate is tender.
That's when the smile on the face comes in. Okay, now I know. I'm actually not in pain anymore.
Yeah.
So, I mean, they need that objective thing because you're still having aches and pains in this part of the body. Now, you're not understanding whether this is now coming from my prostate or is it just because I stretched a bit too much yesterday or something. So that also gives me the satisfaction that, yes, the prostate now feels better. It doesn't feel normal. It's too early because the effect of the shockwave goes on for 6 to 9 months. So it takes that long for it to sort of completely heal.
And like most physical therapies, I mean, this is also very important to emphasize that all these physical therapies, also, for example, stem cell therapies or diet or exercise, doesn't show immediately. You need, I tell patients always at least 3 months.
Yes.
After 6 months, you start to be happy. And after a year, if you are going through with it, that's where it really is a change, a big change there. Yeah, correct.
So now, as I told you, I've been doing this for the last 7 years, since 2017, June. I distinctly remember when I got the equipment. And I've treated a lot of patients, in numbers in the thousands. So I know from my own little practice, now this is level 4 evidence, that I have very few people who have come back to ask me for treatment again. I have, but very few. So in theory, there are studies that have looked at patients up to a year.
Yeah.
There's maybe one that's looked up to even 5 years for that matter. But the problem with these patients is this. Most of them are young. Most of them are not going to come back for follow-ups to you because they're well already. It's so difficult.
As long as it doesn't hurt, people are forgetting it.
They will forget it and they get on with life because now other problems crop up.
On one side, nice for us, it's a little bit of a problem because it would be nice to follow up and see how also they do. And again, from my perspective, how the all over CRP inflammation is coming down from something that is not high, 3 to 5, maybe 6, coming down to below 1, ideally below 0.5.
Excellent.
And with that also a development or in a positive development for the all over health. Now, what would be then the differentiation between a chronic prostatitis and a chronic pelvic pain syndrome?
There's very difficult. There's none, actually.
So that's a pure wording.
It's just a pure wording thing. And as far as I'm concerned, to me, every pelvic pain in a man usually stems from the prostate. That is the where the starting point is there. The rest of it is all collateral damage. So today you have tightness of your adductors. It's all started from your prostatitis causing it. So you are going now to the physio to get your adductors released. You're only treating the collateral damage. And that's going to come back again. So you become a permanent feature in the physio department now. But if you go and treat your prostatitis, there's a chance that muscle is not going to relax with your prostatitis treatment because that's already now stiff. You still need to get it physically treated. But you have to treat some primary cause first to stop this whole vicious cycle of it recurring and returning.
So end of the day, you're telling that the size of the prostate doesn't really matter end of the day. It might
it helps.
It helps if it's smaller.
Helps if it's smaller. It helps in people or helps clinicians to a large extent to decide what kind of surgery or intervention is required when it's required. Because there are people who, to have such enlargement, may it be secondary to an adenoma or inflammation. Adenoma means a real growth of the gland, not just inflammation. And they will need surgery. So the size then helps us decide what kind of procedure is beneficial for you. Because not all procedures have the same result, side effects, and complications based on the size of the prostate. So the size is very important in that aspect. But if somebody walks in today and is not bothered, very minimal urinary symptoms, the size really doesn't lead me to make a choice of treatment. It just tells me, yes, something needs to be done, but there are many options then to me.
And there, the next step in problems would be then cancer. So the size matters on that.
Of course.
The more cells I have, the more possibilities are there that one goes haywire and creates a cancer. So there, a smaller prostate is
There is a
definitely
little bit,
less risk.
Yeah, that is something which, again, I don't really totally believe, because we who have been doing prostate surgery for cancers, prostatectomies, a lot of times our prostates, we are removing a normal sized prostates. They have to come in with just raised PSA, and then, so what you are saying probably will be when actually it is more relevant to treat the prostate cancer, because now it's grown in such a volume that it needs to be treated. Whereas now, because of the PSA and because of early biopsies and MRIs, we are catching very early cancers.
Yes. Luckily, I mean,
Which
this
is good.
one
Which
one
is
of
good.
the cancers where it's 99% curable.
Correct.
Curable, not
Treatable.
treatable, curable.
So that is one of the other contention points where there are a group of people who believe maybe now we are over treating prostate cancer, because
Yeah, that goes around since 10, 15 years. But again, I'm a firm believer in, as soon as you have cancer, treat it.
Treat.
Full stop.
there was this big study done in Europe about active surveillance, where they looked
Yeah.
at just following patients up with yearly MRIs, biopsies, and they found a lot of people, nothing changed in 10 years. But after that, they did stop the study, because I think there was no traction for it. Because, as you said, when people hear the big word, big C, they just want it out of the system completely. And
I would be exactly that person. And I'm again, family-wise, my dad had it. My dad had 3 types of urogenital cancers.
Oh, God.
All of them primary cancers.
Right.
He not had once chemo or radiation, all surgically treated. Big surgeries. Luckily for him, he had a bladder cancer, and a friend of ours, Professor Houtman, who was developing the neobladder.
Oh, Houtman pouch.
Yeah.
Okay.
Yes.
Okay.
Yeah. Exactly. And took care of it. Fantastic job.
Great.
And at the same time, then prostate cancer, but that's more than 15 years ago.
Wow.
And never recurrence. So get it out as fast as possible.
Yeah.
Of course, it's not nice, and you need at least 6 months to 12 months for fully recovery, but you're free of cancer. Yeah.
No, I agree. There is definitely no way to contend with that understanding, because that is what is most commonly understood by us clinicians. That once it's there, it is going to do something bad to you eventually.
Correct. Yeah.
So, anyways, that's a discussion for another day, maybe in the future when.
No, but this is really something where and the inflammation is also progressing to cancer.
Yes.
So any inflammation, any redness on your skin might turn into something.
The only thing is, of course, with prostate cancer, that link has not been documented. So in theory,
The causality is not there. So that hasn't been documented. But
the causality hasn't been documented. So it'll be wrong for me to say that, yes, that is how it should be. But logic tells you that.
Correct. Physiology is very clear.
Exactly.
If you have an enlarged, inflamed tissue, there the chance that it becomes cancerous
It's a real possible
is
thing.
very high. Okay, so that's definitely something that I think we should get out in a big time, and I'm very thankful, and I think we should come back maybe with details on the show notes.
Yeah.
I would be very, very thankful if you have some papers that we can put on.
Actually, I do. I have a lot of things I can share with you. Yeah.
And a recommendation would be, in your opinion, that from 25 on, 30 on, a yearly urological checkup should be sensible, mandatory for male?
I think that's a little bit of an overkill. What I think is what I would really want men out there to understand is any change in the urinary habits, any change in their sexual function at any stage of your life warrants attention. Don't take it for granted that it is your smoking, your drinking, your stress at work, your...
Don't Google doctor it.
Don't Google doctor, of course,
Yeah.
definitely.
Yeah.
But stop blaming the things which people normally blame
And say it's normal.
and say it's
age.
normal to happen when you are
Yeah.
doing this.
Yeah.
It's all right to get up and pee at night because you were stressed at work yesterday.
Yeah.
No, it's not supposed to happen. Yes, stress can make your prostate inflammation worse. That's for sure. Like
Yeah.
any stress.
Correct.
Right? Can aggravate inflammation. But yes, do know that there's a potential cure for this. And that cure, if it is done early, may actually prevent further complications which will happen to you in the future.
Correct.
So last
and
point,
not just urogenital.
just not usual.
Yeah.
And the last thing which I wanted to highlight to you, there was a paper out in 2022 from Japan, first time in history, who showed how men with CPPS had a lower quality of life. Nobody looked at that. The Japanese did. 40% of the patients were depressed.
Oh, that I can absolutely.
40%.
Yeah.
In that
Yeah.
group of people they studied, 6% had already attempted suicide.
Oh.
Now that's a big number. 6 out of 100 patients had
6% I find high, but 40% honestly I find even slightly lower.
It should be
because-
higher, yeah. Possible. Yeah.
I think that should
So
be
it's
actually higher.
it's horrible that something like this, which is so manageable,
Yeah.
is left alone, and men just don't suffer from what's happening down there. What's happening up here?
Yeah.
Productivity, happiness, relationships, everything goes into a little
the
bit of
drain,
a risk.
Yeah.
So yeah,
Great. Thank you so much. I found it not just helpful,
Yes.
but also for me personally. I'm seeing you next week.
most welcome anytime, buddy. Please come.
Great.
And yes, I really look forward to seeing you again. And I really enjoyed this.
Thank you,
This is
thank you,
very
thank you,
nice.
thank you. Then definitely we have a recurring guest.
Definitely,
Thanks,
I'm
Doctor.
more than happy.
Legal disclaimer. This podcast and website reflect the opinions of Dr. Gabriel Peter Salgo and his guests. The content provided here is not intended as medical advice and is solely for informational purposes. Given the unique nature of individuals, it is advisable to consult a healthcare professional for any medical concerns. The views expressed herein are our own and do not necessarily reflect those of our respective workplaces. While we strive for accuracy in the information shared, we welcome feedback and corrections. Privacy is paramount to us, and any references to individuals, locations, or scenarios have been altered to safeguard patient confidentiality. This podcast and website should not be construed in a legal capacity, including establishing a standard of care or as the basis for expert witness testimony. We do not guarantee the accuracy of statements or opinions expressed herein. Engagement with our content, whether through listening, reading, emailing, or social media interaction, does not establish a doctor-patient relationship. Should any errors be identified in our content, please contact us through the provided channels. Ownership of this podcast belongs to Pura Vida Healthline SDN BHD. Our content may include affiliate links, through which we earn a commission on sales made through those links. As a participant in the Amazon affiliate program, we may earn from qualifying purchases made through our links. Disclosures. Dr. Gabriel Peter Salgo is the co-founder of Pura Vida Healthline SDN BHD. Dr. Gabriel Peter Salgo is a scientific advisor, board member, and/or investor to Mulligan H. Jada Kind Ltd., Eichsen Research, and receives compensation from these companies.